but centered on cancer navigation. And I know from looking at who's here that there are some experts in cancer navigation in the room. And I want to let you all know that there is an audience participation component of my talk, and I'm not kidding, okay? So at a certain point, I will stop talking and ask you to help me. And the reason for that is exemplified by what Dr. Hessen was talking about. Most of our good ideas come from people on the front lines of care and from patients and from caregivers. And part of what I want to use my time to do today is to think about one of the challenges that we have in cancer navigation. And so I'm going to kind of do some background on cancer navigation and talk about the evolution of the framework of cancer navigation as it's happening right now. But in order to kind of do that, we have to understand where cancer navigation came from, because that is what sets us up for the conversation that we're going to have today. And cancer navigation really took hold between the 80s and the 90s as we began to see cancer outcomes improving for people, as we saw that chemotherapy actually did work, people could live longer with cancer, but some groups were being left behind. And the groups that were being left behind were those groups that were not as well resourced. So impoverished people were being left behind and were not benefiting from the advances that we saw in survival for other groups. Racial and ethnic minorities were being left behind and were not benefiting. And navigation really began because Harold Freeman, who was a surgeon who worked in Harlem, identified that his patients, his breast cancer patients who were poor African American women, oftentimes did not do nearly as well as you would expect them to if you were looking at national data. And he was very concerned about this and really wanted to understand why that was happening. And it remains a fact that people who have lower incomes are more likely to die from their cancer than people who don't. And you might sort of think, oh, well, that's sort of the result of maybe not having good insurance or something like that. But it's consistent and it's across populations that if you are financially poor, you're not going to do as well. And there's been a lot of work to sort of understand these disparities that occur in cancer. And the American Cancer Society in 1989 held a series of hearings around this and found that it's not just issues with survival, but that people who are disadvantaged also have greater symptom burden, are more likely to experience economic devastation as a result of the disease and their treatment for it, and make tremendous sacrifices to get care. They face obstacles in obtaining and being able to utilize health insurance. And they don't seek care if they can't pay for it. So that a woman who does not have health insurance, who discovers a lump in her breast, may delay for months and months, or even sometimes longer, the workup that would allow us to identify that that was a cancer and then engage the supportive sorts of resources that we have to help people who are financially at risk. So what Dr. Freeman and others recognized was that many things impact health outcomes besides just the biology of the disease and whether it was responsive to the treatments that we utilized. And these sorts of things include income, personal health practices, behavior coping skills, social support networks, whether they're employed, whether they're working, their working conditions, their physical environment, the neighborhood that people live in. All of these things impact how people do with treatment, how able they are to engage with treatment, and how whole they get through treatment. So there was a recognition that we needed another approach to cancer care that helped support people in accessing care. And one of the basic rules in cancer care delivery is that identifying tumors early is critical. And getting people into care early is critical. And that's because we have much better success treating early tumors than we do treating late tumors. In fact, it's the primary thing that determines how people do with a cancer diagnosis. And when they began to study this problem with disparities, they recognized that there was a critical disconnect between the science that was happening and our ability to deliver that science to people who had the disease, with a real focus on access to care. And that this was determining why cancer affected people unequally. And so navigation was an approach to try to overcome some of those social determinants of health that impacted people who had low resources or came from cultures or communities that did not readily access the health system. And the focus of patient navigation at this point was really on this issue of screening and access to care. So this was in the early to mid 1990s into the 2000s, and well into the 2000s. This was the focus of cancer navigation. And in fact, almost all of the science that has been focused on cancer navigation has focused on access to care and access to screening services. And there's very little science that focuses on any other aspect of the cancer trajectory. So there have been many studies that demonstrate that screening or that cancer navigation improves cancer screening rates, particularly in vulnerable populations. So we know that we can use different strategies to place navigators in communities and to pull navigators from communities to improve screening rates within that community. And then once we get women to get their mammograms, we can lay in support to ensure that they can get the rest of the treatment that they need. We've also got robust evidence that cancer navigation improves time to diagnostic resolution. And what that means is once somebody has a screening test that's positive, we can shorten the time that it takes to get them into the system and to get a clear and final diagnosis made, which again facilitates early treatment for their cancer. So there's no question that cancer navigation helps with those steps of the cancer trajectory. And it makes perfect sense, right? Because that is where cancer navigation originated, and that was the entire focus of what we were training navigators to do in that period of time. But there are no studies, and I mean none, there are no studies that show that cancer navigation improves quality of life for patients. Now that seems counterintuitive, doesn't it? Like if I had asked you before I started, do cancer navigators improve quality of life for the patients that they're helping? We would have probably, almost all of us in the room, raised our hands because it makes such perfect sense, right? But either we haven't studied it the right way, or we haven't trained navigators to do that work yet. And I think in truth, probably both those things are factors. We haven't done a good job of setting up studies to allow us to measure what navigators are doing. And we have not to date trained navigators to do the sort of work that really delivers person-centered cancer care. So this is the activity part of things. How would we redesign cancer navigation to improve outcomes that are important to the patient, right? And that means, I'm not trying to suggest that being diagnosed and getting into care is not important to patients. Of course it is, because they'll live longer if we can do that. But what would it be to deliver cancer navigation that improves outcomes for patients? So you have to think, what are those outcomes that are important to patients? And what sorts of things could navigators be doing? So what I want you to do is to take the next 4 minutes, and only 4 minutes, and at your table, and if you're a lone wolf, join those guys, at your table, have a conversation about that, And then in the final minute, I want one person from your table to sort of nominate your ideas if you feel like it. This is not forced participation, but if you feel like you had a good idea, and look, I have a notebook, so I'm going to steal your good ideas and study them, okay? For real, go, 4 minutes.
4 minutes.
So if I can summarize and reflect back to you.
They're loved more.
Yeah, they are loved more. But that development of a meaningful relationship is a huge component of delivering patient-centered care, right? And so I heard a lot of things that really resonate with me, which is help patients and families prioritize their goals in that process, sort of managing realistically what they can hope for and what they can expect. Those sorts of things are really, really important. One of the things that particularly community-based navigators bring to the table that sometimes we struggle to have the same sort of impact with health system-based navigators is that lived expertise. By being members of the community that they're coming from, laypersons sometimes bring a lived expertise in the culture that can be incredibly valuable in those sorts of communications that are about meaning and that are about developing meaningful relationships with people. What we did, what I'm going to spend the next few minutes doing is just describing a program that we sort of developed around these same ideas that you came up with to try to help patients not just getting into treatment, but across treatment and into survivorship or palliative care, kind of no matter what direction their disease was carrying them, that they would feel that supported and meaningful support of our health system in their journey. So this is a quick film clip, and actually I have to pull it up over here. Oh, good. Oh, for God's sakes.
A little over 2 years ago, James and Joyce Whitener started on a journey they didn't choose, and one they really didn't understand. James was diagnosed with cancer.
Devastating at that time, yeah, because we all think that we're someone who's going to live a long, long time, and when they tell you that, that takes away a lot of that. And very frightening to begin with.
Frightening and confusing.
Well, you don't know what you're going to do. You don't know where you're supposed to go, what all it entails in getting through this. Yeah. It's just confusing more than anything.
But that confusion cleared up when John French III showed up. He's part of the Patient Care Connect Navigator program at the University of Alabama at Birmingham. The concept, to offer cancer patients access to trained experts, or navigators, who can assist in charting the often challenging path of cancer diagnosis and treatment.
The navigators help them to overcome logistical issues, financial issues, emotional issues, social issues. We actually, when our navigators first meet the patient and the family, they do what we call a modified distress thermometer. So they actually go through all of the domains of care, whether it's emotional, financial, transportation, and so forth, and identify, barriers to receiving the care. And then they are trained to actually help overcome those barriers.
Each navigator typically works with about 100 patients. They're full-time employees of the university, and their services are free to cancer patients and their families. The services vary based on patient need. But the one area navigators do not touch is anything medical.
Not so much as patient care or along the lines of anything that's clinical, but just being there, having a liaison between, the patient and the hospital, pretty much being the advocate, being a voice for those who don't know what to say or how to say it, and at times get lost in the weeds.
Currently, there are about 56 patient navigators in the Patient Care Connect program. That's the program James is in. It targets cancer patients over 65, but there are navigator programs for many patient groups. Each one includes a medical professional.
Each one of our navigator teams has a registered nurse that sort of serves as the leader, so they can bump a true medical problem up to the nurse who can help them solve it. If she can't, then she bumps it up to the physician's office to be solved.
The aim is to take a holistic approach.
We believe that this program is a really great link between the healthcare delivery system, the physician office, if you will, and the home where the patient is spending most of their time.
Time that Joseph would call and say, John, I don't know how, I just need a prayer. I just need someone to talk to. Because things are tough, and that's one thing that we also factor into the model here with this program is that, we look at the patient from a holistic view. Is that family members count also, caretakers count also. So I try to make sure that my service just doesn't stop with him. It goes, George or his son Marcus or, his daughters, anybody that encompasses his care, I try to make sure to make myself available to them also.
James' cancer is currently in remission, and for the white nurse, John's assistance was and still is a blessing.
Well,
that was John French, who was with our Patient Care Connect program here, is now down at Mobile. And he's describing, and the CNN person was describing the Patient Care Connect navigation program, which was built around the principles that if I'd given you more than 4 minutes, you would have developed, focused on patient-centered navigation. And we implemented that across 12 centers in the Southeast in 5 states, in Alabama, Mississippi, Tennessee, Georgia, and Florida. And at our peak had as many as 56 navigators. And many of those people are still working in navigation, although the funding for this specific program has been expended. It was impactful enough at those centers that they decided to bring those navigators in and fund them independently. The goals of the program were focused on things that patients told us were important to them. They told us that it was important that they spend most of their time at home. Particularly if they had serious illness, they wanted to avoid unnecessary trips into the hospital or to the emergency department. They wanted to receive technically competent, cutting-edge cancer care. And in terms of quality metrics that we added, we wanted to encourage earlier adoption of hospice care because we know that care for patients who have serious illness is better if they enroll in hospice earlier than if they wait a really long time. But overall, our goal was to provide the highest quality of life for patients who were diagnosed with cancer. And we utilized community health workers or lay navigators who were integrated into the cancer care team. And as Dr. Partridge said, there were specific pathways for the navigators to escalate medical problems into the medical team when they encountered them, which is really important because these were not medical professionals. They provided support and coaching to patients no matter where they were in the cancer continuum, whether they were patients who were coming into care and needed assistance with access, or whether they were persons who were no longer going to be getting cancer treatment and needed assistance with the care transition into hospice care. The navigators were able to help people across that entire trajectory. Our goal was really to hardwire the system to support active, engaged patients with a proactive, responsive, and patient-centered infrastructure. So when we think about patient-centered, the whole idea of opening every encounter with an assessment of what was happening with the patient and utilizing that distress tool to frame each patient encounter was probably sometimes burdensome, but it meant that at each encounter we were really stepping back and taking a look at what was happening with the patient and then framing our care around that rather than around our goals as the cancer treatment program. So our community health workers or lay navigators are established members of the community that they're serving. We asked all the cancer centers we were working with to specifically recruit community members who were natural helpers, and they got to define what that was. They were responsible for their own recruitment at each of those 12 centers. And we got an array of folks, a lot of retired people, cancer survivors themselves, and oftentimes people who had some level of medical exposure or some level of medical expertise, but were not healthcare workers themselves. We wanted to measure how we impacted the quality of the care that patients were receiving. And we utilized quality measures that were developed based on the National Quality Forum measures in palliative care and existing care guidelines for cancer care. Ultimately, we ended up revising what we were measuring to utilize the Choosing Wisely measures, which is interventions that professional bodies like ASCO or the Society for Radiation Oncology agreed were appropriate and utilized those. And then we were able to evaluate the impact of care through claims data. As I said, we used distress screening with an adapted distress assessment tool, and that was incorporated into each interaction. And among the more than 5,000 patients that were eligible for navigation, the vast majority of them completed more than one distress assessment in the time that they were in our program. These are the sorts of data that we got back, and this is data from the distress tool specifically. It's very interesting. The blue column reflects that the patient reported that that particular item was an issue for them. So not surprisingly, we see a lot of patients had difficulty with pain and fatigue. Those are the sorts of things that we would expect. Functional mobility problems was an item that we actually added to the distress assessment because we were dealing with an older population and felt that might be an issue for them. It turned out that we were correct in that. It was very frequently an issue for our patients. The red column indicates that the patient or family member requested assistance with that item. And this is where it's interesting. You can see that they were much more likely to request assistance as compared to the number of people reporting issues with knowledge gaps, things like questions about their treatment, questions about their diagnosis, questions about diet or nutrition, than they were about symptoms. And we sort of suspect that patients and families were sort of self-editing what they were asking their navigators to assist with. The green column reflects that on the next assessment, the patient or family member reported that the problem had been addressed. It does not mean that we think that it went away, but they felt like it had been addressed to their satisfaction. Because I don't think that we helped all that much with fatigue, obviously, but they felt like they had been heard and that we had generated something that responded to their concern. Overall, this program made a vast difference for patients, not just in terms of symptoms and symptom burden, but also in terms of how they utilized the health system, in that they were much less likely to be hospitalized than patients who didn't have this level of support. That's not that surprising. They were less likely to use the emergency department. And the cost of caring for these patients decreased dramatically. So their care got better, and the cost of caring for them decreased. In the patients that we looked at who actually went on to die, again, we see those decreases in hospitalizations and emergency department visits, and we did see an increase in hospice utilization as well. We saw costs that decreased 30 days, 90 days, and 180 days from end of life. So the impact of this program began well before these folks transitioned to hospice. Overall, emphasizing, and it was in the end of life group that we really saw the biggest impact of the program in terms of their impact on healthcare utilization. That was the group in which this was most marked. So in summary, cancer navigation is evolving as we ask more of this novel of care. When this idea was first conceptualized in the late 80s, it was really about getting people into care. Now I think we're beginning to appreciate the power of this type of intervention to impact cancer care across the entire trajectory of care. And thinking of ways to design programs to allow this type of care for patients who need it. Oftentimes, those most vulnerable patients, those patients who are not necessarily going to be well equipped to respond to the sort of support that Pac Health might provide for other patients. So this isn't, the only model that works, but it might be a great model for helping patients who are otherwise very vulnerable. Science is lagging behind what many of us observe clinically. There still isn't a good randomized controlled trial that shows an impact of navigation on quality of life. I hope that we'll change that here at UAB, but it doesn't exist yet. Our study was not a randomized controlled trial. It was a very large implementation, which means that we can't say for certain that it was the navigation intervention that was causing those effects that we saw. So we're still studying this, and we need well-designed trials to help us measure the impact of navigation and optimize this intervention. And we need people like you thinking good ideas about how we can improve care, because that's how science happens. It's when the clerk in the OR says, well, actually, we could do better at this. Or it's when the navigator in the field says, well, actually, it would work better if we did it this way. So anyway, if any of you have good ideas and want to share them after, I'll be around, and I'll take questions now.